we either pull our boots up and we move forward, or the specialty is going to cease to exist. And you're now the chair of the Workforce Committee.
That's correct. As of July 1st, I'm chair of the Committee on Pediatric Workforce. During the last year on COPAM, it became apparent that we were starting to see issues with the pediatric workforce, with the number of new graduates choosing to enter pediatric residencies and the number of graduating residents choosing to go further and enter pediatric care, whether it be general pediatric primary care or subspecialty pediatric care. And at that point, it looked like we were reaching possibly, as you said, an inflection point, but possibly even a more existential crisis for the specialty of pediatrics. We know that the population of children in the country is fairly constant at around 73 million, and it has been so over the past 10 to 15 years. So we're not seeing a growth in population, but what we are seeing is a growth in need for access to pediatric care. And the pediatric establishment, and I don't mean to use that in a negative sense, but the entire field of pediatric medicine is not responding with the increased growth in the number of pediatricians available to help provide that increased access. So even though the number of children may be constant, the demand for pediatric care is rising, and we're having trouble meeting the need for that, meeting the demand for that care in terms of our numbers.
And it's not only the number stable, the makeup of that population is changing. The Anglo population is not reproducing, while the immigrant population is. So the children are looking a lot different than the population in general.
That certainly is true, but while the population may be demographically looking different, all children have the same basic healthcare needs. Some may have greater needs than others, and we may see that in people who are coming to this country from areas where their access to healthcare has been poor. So we may see greater needs in some of those children, and we certainly do find that recent immigrants are having a greater need for pediatric services. But children are children. They still need basic preventive care, which, after all, is a large part of what we do. They still need the screenings for detection of less common illnesses. They still need the mental health care that we're seeing, arguably more now than in the past. So all children, no matter what their origin, no matter their race or ethnicity, all children still need a certain basic level of pediatric care. And one of the things that pleases me over the years that I've been practicing is that we are extending that care to greater and greater numbers of children who previously were underserved.
And then the other thing I see in the clinic is the case sets have changed. And now it's mental illness and metabolic disease. And part of it is because of the clinic that I help, right? It's a high immigrant population, many from Latin America and from Southeast Asia. And so the Central Americans have a greater degree of obesity and type 1, type 2 diabetes than the population in general. And the South Asians also are afflicted at a greater number of with type 2 diabetes. And so the complexity and the time that it takes to figure these cases is more significant than it used to be to look at the kid with bronchiolitis, otitis, chickenpox. They were fairly quick visits that everybody got the same symptoms. And I didn't have to think too much about if you're not white, black, and your hemoglobin A1C is a little elevated, the black population normally has a little bit higher hemoglobin A1Cs. That may not be a pre-diabetic yet. All those little things are just more work to be done without the education, because that's not what I learned in residency.
That's certainly true. We've gotten good at managing a lot of pediatric conditions that used to lead to significant morbidity. I think back over the years in practice, and during the last 5 or 10 years, I don't think I admitted a kid with diarrhea and dehydration or a kid with asthma. We got good at managing those things. That used to be a big part. We've also gotten good at preventing infectious diseases with our vaccination program. The infectious diseases like invasive pneumococcal and invasive Haemophilus disease that were a big worry for us many years ago are no longer so prominent or so prevalent because we have effective immunizations. So we have changed the nature of what we handle and the conditions that we manage on a regular basis.